The next section is on coagulopathy. How often does coagulopathy occur, and what should we do about it? Many patients who have ICH are not coagulopathic. However, we recognize that the use of warfarin, other vitamin K antagonists, and newer anticoagulants, as well as the use of antiplatelet agents, are very common in our patients, especially those with coronary artery disease and those with atrial fibrillation, where we're trying to prevent subsequent ischemic stroke. So the principle we want to follow: any ICH in a patient on warfarin or another anticoagulant should be considered life-threatening. And the reason I use that term life-threatening is that's what shows up in guidelines. It's tempting to see a patient who has a small hemorrhage and think, well, this is not too bad. I don't need to worry so much about reversing the coagulopathy if their INR is elevated. But in fact, that's the very patient we can do the most to save, because that's a patient who's in good condition. And if we allow the hematoma to get bigger, they're going to be in worse condition. It's a fair question. Does urgent reversal of warfarin improve outcome in ICH? And I use warfarin or other vitamin K antagonists as the example because we have the most experience with those. There have been no pivotal phase 3 randomized trials that have really even addressed this question. The INCH trial, which was published earlier this year, actually showed a very strong trend towards improved outcome and showed decreased hematoma expansion in patients who had reversal, especially those who had prothrombin complex concentrates used as opposed to fresh frozen plasma. And we know that PCCs reverse the INR faster than fresh frozen plasma and have fewer cardiopulmonary side effects. So I mentioned before, we have a lot of experience with warfarin and other vitamin K antagonists. They've been around a long time. We use them a lot. And now in many series, it's said that about 10% of spontaneous ICH is associated with warfarin. Now you got to remember, if that patient has a thalamic hemorrhage and they have chronic hypertension and they have an INR of 2.5 due to treatment with warfarin because they also have atrial fibrillation, that's probably just a patient who had a hypertensive ICH and happens to be on warfarin. And frankly, it probably doesn't really matter either way. They still need to have their INR reversed. They still need to have their blood pressure controlled. But we have an increasing incidence, as we said, with aging of the population and the more use of these agents. Warfarin use is clearly associated with worsened outcome, more hematoma expansion, and if you don't reverse it properly, the bleeding happens over a much longer period of time. Now, in many parts of the world, we have these agents called NOACs, novel oral anticoagulants, or non-vitamin K antagonist oral anticoagulants. These come in usually two general categories: direct thrombin inhibitors, such as dabigatran, and anti-10A agents, such as rivaroxaban, apixaban, or edoxaban. And these have been studied a lot recently and have demonstrated equivalence or superiority to warfarin for stroke prevention and atrial fibrillation and deep vein thrombosis treatment. They may actually even be safer than warfarin, in particular apixaban. The problem is none of these agents had an exact direct reversal medication when they were released. So here is a diagram of the coagulation cascade, and I'm sure most of you have seen this before. Here's what we're used to. Vitamin K antagonists, which impact on factor 2, 7, 9, and 10. And so the reversal of these agents involves giving back things that reverse that. So fresh frozen plasma has these factors in it and can be very effective. Prothrombin complex concentrates, I think of sort of like freeze-dried fresh frozen plasma. You can give a larger amount in a smaller volume. And then, of course, vitamin K itself. The anti-10A agents work very selectively on factor 10, and dabigatran works on thrombin. So obviously, any reversal of these agents is going to have a different strategy. I will refer you to a recently released document, the Guideline for Reversal of Antithrombotics in Intracranial Hemorrhage. And this would refer to both spontaneous ICH, like we're talking about today, as well as traumatic intracranial hemorrhage. And this was a guidelines that was developed by the Neurocritical Care Society and the Society of Critical Care Medicine. And I think this is a very useful document that forms an approach that we all ought to be taking. And this is the summary of the recommendations. If the INR is elevated in a patient with intracranial hemorrhage, every patient should get vitamin K. The problem is vitamin K doesn't act very quickly. So it's not effective for reversing the patient's INR quick enough to avoid hematoma expansion. So they need to receive something else. And if you have 4-factor prothrombin complex concentrate, PCC, available, you should give that. It's probably going to be better than FFP. If all you have available is FFP, then you can give that. The thing you have to appreciate is you usually have to give relatively large volumes of FFP. So a patient who has an INR of 2.5 might need much more than 1 to 2 units of FFP. They may be needing 1 liter or 1.5 liters of FFP. That's a lot of volume. So that's going to be our approach. The reason you give vitamin K is the PCCs or the FFP, they only last for a few hours. And if you don't give vitamin K, there'll be a rebound elevation in the INR. So in many parts of the world, these newer agents are being used more and more. So what do you do? Well, for direct factor 10A inhibitors, we don't have a very satisfactory approach. You can try using activated PCCs, such as something called THEBA, factor 8 inhibiting bypass activity, or 4-factor PCCs. But this is not really completely satisfactory. For dabigatran, there is an agent that is a direct reversal agent that's just been released. It's not available everywhere, but it is available in the US, and it will probably increase in its availability. It's called Idarucizumab. The other thing you can do is you could try PCCs. Okay. Recombinant factor 7A used to be considered, but is no longer recommended. So refer to these guidelines because these are really useful when you're developing your own hospital protocol or order set. I mentioned Idarucizumab, and this is an interesting agent. It's a monoclonal antibody fragment that binds dabigatran, both free and bound to dabigatran. And it's been demonstrated to have improved hemostasis. So this is a very selective agent. Unfortunately, it's very, very expensive. I'm going to show you an example of 2 order forms from our hospital. And the reason I show this is every hospital should have a standard protocol for this. This does not work very well when you make it up as you go along. And you can anticipate this. Coagulopathy will occur in patients with ICH. Here's our warfarin reversal order form. Some of you have electronic charting, some of you have paper orders. Whatever you do in your hospital, that's fine, but have a protocol. So you see here we have acute major bleeding judged as life-threatening. So the example here, any intracranial bleeding. We also have something down here where a patient is getting emergency surgery. So remember, this is not just for intracranial hemorrhage. And you don't need to reverse them as quickly. All our ICH patients are going to be up here in the life-threatening. And so we give vitamin K. We use an agent called Kcentra, which is a 4-factor prothrombin complex concentrate. And we dose it based on the INR according to this. And then we repeat the INR and check again. We also have an order form for the direct oral anticoagulants. And this is what we do. Life-threatening hemorrhage, any ICH. We discontinued dabigatran. We may give charcoal, but this isn't that great. And then we use Idarucizumab. But if it's rivaroxaban or apixaban, we use activated charcoal, and then we give our Kcentra prothrombin complex concentrate. The point, once again, is go back to the guidelines and develop a standard protocol so that you can use this in an emergency in your patients. Because time is of the essence. You've got to get that coagulopathy reversed. Now, a really interesting study came out last year. And it was not a randomized trial, but it was a observational study of over 1,100 patients. And they looked at over 800 of them for hematoma expansion. And a lot of them had hematoma expansion. But they looked at two things we've been talking about: blood pressure lowering and coagulopathy reversal. And these were all patients who had anticoagulation-related intracerebral hemorrhage due to a vitamin K antagonist. Excuse me. And what they found is there was reduced hematoma enlargement if you got the INR reversed quickly and the systolic blood pressure down. But the combination of the two was better than doing just one or the other. And this is a really important idea. The idea that there's a synergistic effect. Doing both blood pressure lowering and coagulopathy reversal was better than just getting one or the other. And that's really important. And that emphasizes that we're not treating all these things in isolation. We treat it as a package of good care. Now, one question that came up when we wrote the guidelines, and it comes up a lot, is what do we do with patients on antiplatelet agents? We think that antiplatelet agents increase the risk of hematoma expansion. Not as bad as anticoagulants, but they do. But we don't know. A study came out earlier this year called PATCH, and they looked at patients who were not that severely affected, who had spontaneous ICH, and they gave some of them platelets, and they gave some of them, sorry about that, stroke code on my pager. So they gave some of them antiplatelets, and actually, could you stop that? But one of the questions that comes up a lot is what to do with patients who have an ICH while they are taking antiplatelet agents, such as aspirin or clopidogrel. And this is pretty common. We think that the use of antiplatelet agents increases hematoma expansion. It's not as bad as anticoagulants, but it is a concern. And so we haven't had good data in order to help us understand what we ought to do. And that's why the guidelines said that the use of antiplatelets or platelet transfusions is unclear and investigational. Earlier this year, a study was published. It's called PATCH. And this study took patients who had intracerebral hemorrhage while they were on antiplatelet agents. Most of them were actually on aspirin. And these patients weren't particularly severely affected with ICH. But they studied giving platelet transfusions versus not giving platelet transfusions. Excuse me. Interestingly, what they found is the patients that got platelet transfusions did worse. And this surprised a lot of us. So our conclusion now, the best data that we have, is platelet transfusion in mild to moderate ICH is not beneficial and may be harmful. I actually used to give platelet transfusions in these patients, and I have stopped since the PATCH study. There are a number of other studies ongoing that are looking at the impact of platelet dysfunction on ICH. But for now, PATCH is the best data that we have.